this is going to be an introduction to the geriatrics. Going to go through a case study and just a few little brief things before we dive off into each section here. So with your case study, you've been assigned to orient a newly hired paramedic, Mike, who just graduated school 7 months ago, and your focus today has been working kind of on geriatric emergencies. Your territory has service to 6 nursing homes and assisted living facilities. Your unit's dispatched to one of those smaller nursing homes for a sick person. So you get there, you're escorted to the day room where the residents spend most of their time. You have a nurse sitting next to a patient who's in a wheelchair by the window, and they wave you over. She introduces you to Miss Howard, who is a frail 86-year-old widow, and the nurse explains that Miss Howard's been running a low-grade fever since last evening. It's just not acting like her normal self. The physicians requested she be transferred to the hospital to be evaluated. When you ask her how she's feeling, she kind of slowly turns, looks at you, and says, "Not well." Okay, so primary assessment. When you look at her, it looks like a kind of a frail, weak, elderly woman. She is alert. Her airway is open and clear. Her breathing is adequate chest rise in volume. It is non-labored. Her circulation strong with a rapid radial pulse, and it is irregular. Okay, so why is it so important, do you think, to review kind of the more common medical problems of elderly people? Why would this be something you want to work over or go through with a new paramedic? Elderly populations, some of the largest consumers of medical resources. There's some like 45 million Americans that are older than 65. That's more than 10% of the population. And as we get older, our bodies are going to change. There's a lot of physical effects. There's a lot of psychosocial effects. And typically, the older you are, the more medications they're going to take. So you have more signs and symptoms, polypharmacy, that kind of stuff. So going through and understanding how these different medical problems or issues can affect elderly is really important, especially when it's a large percentage of who you're going to respond to. So, which organ systems are the most affected by age-related changes? Well, to be fair, all of them really are affected by age-related changes, but the ones that are probably a little more particularly relevant to your elderly population are going to be like your respiratory, your cardiovascular, your nervous system, your musculoskeletal. Okay, so we're talking about it. You realize, hey, this is a good time to do some hands-on stuff. So you ask Mike to start a physical exam while you get your set of vital signs. The nursing care for your patient is new to the facility, of course, and is not very familiar with her. That happens a lot. She is able to tell you that your patient has a history of atrial fibrillation, congestive heart failure, diabetes, hypertension, and is currently prescribed digoxin. I'm not even going to try the P1, enalapril, and I'm not going to try the other E1, and then simvastatin. So what are these for? Well, the P1, that I'm not going to try to pronounce, is an anti-diabetic medication. Enalapril is an ACE inhibitor. The estimibib is for cholesterol. And then the simvastatin is also for your cholesterol. Digoxin, of course, is your antiarrhythmic. So while you're talking to the nurse, another patient comes up to you and introduces herself as Miss Jessup, who's a good friend of Miss Howard. And she tells you that normally they go for a walk every night after dinner, but they haven't done this for the past couple of evenings because she hasn't been feeling well. Right, she also says that she hasn't been eating much over the past few days, but Miss Howard's kind of brushed off her friend's concerns. So you are able to figure out from Miss Howard that the last meal she had was a bowl of soup yesterday at lunchtime. Right, as far as the little conscious, nothing's really changed. She's alert. The pulse is 110 a minute, strong and irregular. The blood pressure is 168/94. Respirations are 22 a minute and regular. The skin is hot, pink, and dry. And she is 93% on room air. Right? So you might be kind of thinking through what's going on with Miss Howard, trying to figure out what might be kind of wrong with her. Why is getting an accurate history and the history of a present illness, number one, super important, but how can it can make it challenging. So how do you work around that? What makes it so difficult? The big thing is that, number one, they may have multiple chronic illnesses. They can be taking multiple medications. They may not perceive pain the same way that a younger person might. They may be able to not able to distinguish acute from chronic. They may not want to go to the hospital, so they may downplay what's going on with them. So there's a whole lot more to it than just the patient's sick, take them to the hospital with your geriatrics. Right, so you get all this information from the nurse and Miss Jessup, and you ask Mike what he found during his physical, and he tells you that the patient seems to be a little dehydrated, has some tinning of the skin, dry mucous membranes, and he also noted some diminished breath sounds bilaterally with rails at the right base. Has an elevated irregular heartbeat and an oral temp of 102. So he asked, what treatment would you like to start with? What are you thinking right now? Well, we definitely need to start some IV access, right? We need to get some fluids to help with the dehydration and the fever. You're able to get a 20 gauge in the left hand. We start some supplemental oxygen, 3 liters, cardiac monitors applied. Only thing really different here, our SpO2 comes up because now we're about 98% with supplemental oxygen. Your ECG shows AFib. Alright, and the blood glucose is 178. So with this, could be a respiratory thing. We had some difficulty there. Respiratory illnesses are pretty common in the elderly population, especially if they reside in an institutional environment like a assisted living or a nursing home. Just it's kind of like college dorms, you know, you're around a lot more people, so some communal diseases tend to go around a little bit more. All right, and she has diabetes, so that's going to increase her risk of getting pneumonia and things like that. Right, so you put her on the stretcher and semi-Fowlers, move her to the ambulance. While en route, she starts telling you she's a little winded. Reassessment shows no changes, and your partner suggests administering a nebulized treatment of ipratropium. All right, you start that and call in a route to the hospital, call and report, and right on to the hospital. Nothing, blood pressure's come down a little bit. Nothing else has really changed a whole lot. So as you get there, patient says she's breathing easier and thanks you for being so nice and caring. Right, she's observed in the ER for a few hours and diagnosed with right lower lobe pneumonia. Okay, she's made it to the hospital for IV antibiotics and discharged for the nursing home on the 5th day. So with your pneumonia, in the elderly population, you're less likely to have a fever, productive cough, chest discomfort, congestion, that kind of stuff. The clinical presentation of pneumonia in elderly people will kind of fool you sometimes. You don't have that classic clinical presentation. You might have somebody who might present with ultramental status, maybe a little shortness of breath, tachycardia, and tachypnea. They may have abdominal pain. They may have no pain at all. They may not have any coughing, because keep in mind, as they age, that cough reflex really subsides a good bit, which kind of contributes to them developing pneumonia more often in the first place. And they may or may not have a fever, or if they do have a fever, it may be more of a low-grade fever just because their immune system is not able to fight the infection quite as well, so it's not as robust, if you will. Alright, so in the pre-hospital setting, our pre-hospital treatment of pneumonia is primarily supportive care. We're going to make sure the airway is open and adequate and patent. We're going to make sure the oxygenation is adequate. We may give some bronchodilators, Atrovent, Combivent, ipratropium and albuterol combinations. Fluids, IV fluids may be helpful as long as there's no contraindications for the fluids. It can be helpful if they're dehydrated, but make sure you check your lung sounds frequently, especially if they have a history of your CHF. You may use CPAP in some places, so it really just depends on the severity with your patient. So geriatrics, we know is just the treatment is patients who are 65 years and older, okay? And I don't know the 2020 census, but the 2015 census, there were almost 45 million Americans aged 65 and older. I would hazard a guess that it's going to be higher with the 2020 census when they release the results from it. Of this, they make up 10-12% of the population of America, but they make up for about 15% of all emergency department visits. So there's a lot of people that a lot of your patients are going to be of the geriatric persuasion. So it's important to understand how diseases and illnesses and traumas and things affect them a little bit differently than some younger counterparts. There's a term called the graying of America. And this is used because the percentages, and a lot of it now is due to the baby boom back after the World Wars, is that people are getting older. They're requiring more health, more help from the healthcare field, but also people are living longer. Our lifespans as a whole, people tend to live longer. Not only that, but people tend to we have better healthcare as a whole, so the people are living longer, have expectations of living of the higher quality of life. And, you know, people are more used to maybe maintaining independent lives. A lot of them don't live in nursing homes. Now, there are lots of people in the nursing homes, don't get me wrong. And there's a lot in assisted livings, but there's also a lot of them out there that are still living on their own, or maybe, you know, like kind of like the Golden Girls, you know, living with some friends and stuff. That's my goal. If my, you know, later on in life, like me and my friends just chilling, doing crafts and stuff every day. With aging, there's a lot of different things to think about besides just how our bodies handle disease and trauma differently. But you've also got a lot of psychosocial factors that kind of go into what they want or don't want done. And I kind of get it. You know, the suicide rates for elderly are going up, which just blows my mind when I think about it. But I kind of get it. You know, if they're older, they're not able to do things that they used to be able to do. And I can see getting frustrated with that. You know, maybe there's activities they like to do that they can no longer do. Maybe they don't feel productive, you know, which can lead to low self-esteem. Maybe they, you know, they don't have that sense of freedom that they thought they might get in retirement. Maybe they don't have that. Things aren't going quite the way they anticipated. You know, their friends, you know, if their loved ones and friends may die, then they may feel more lonely or isolated. You know, if a spouse dies, then that may change their financial concerns. So, you know, if they were maybe relying on their spouse for daily assistance and now their spouse is gone and they aren't able to meet their basic daily needs. So there's a lot of different things that can kind of change as you age that will change what your individual needs are, those geriatric patients' needs are.